So this is our last lab, and this lab deals with two things. It deals with cardiac alterations, which we started talking about yesterday. And we talked about the reason that we focus on what the cardiac silhouette and the cardiovascular silhouette is supposed to look like normally is so that we have some idea when it's abnormal what might be the problem. And so it's the reason that we focus on, all right, which chamber makes up which border of the cardiac silhouette. You know, which chamber's making up that border, which chambers are making up that border. That's why we did that little saying, you know, right is right, front is right, left is left, back is left. Rights are singles, lefts are both. It's so that we remember where the chambers are. Because if the heart is abnormal, the chambers typically enlarge. And when the chambers enlarge, they enlarge usually because of workload, an increase in the workload on the chamber, or they may enlarge because the muscle is diseased, like a cardiomyopathy, which can weaken the heart muscle and cause the chamber to enlarge. So, when we have chamber enlargements, it changes the size and or shape of the cardiac silhouette. And we can actually get a fair amount of information when we know what to look for. But we have to understand that the plain film is somewhat limited in what it can tell us. And the bulk of cardiac information comes from other exams. The definitive diagnosis is not a plain film. It comes from ultrasound, which is very effective. Cardiac catheterization is where a lot of the information comes from. Contrast examinations. So let's take a look at this one. This heart looks a little bit large, don't you think? Mm-hmm. And our cardiothoracic ratio is the widest horizontal. So we'd go, that's the widest, so we'd bring that up. It's not this way. It's the widest horizontal, which would be about there, compared to the widest internal, which would be here over to here. And the heart should be less than 50%. I would put this one at just over 50%, which means this patient has very mild cardiomegaly. The heart is a little bit enlarged. So then we look to see, well, which chamber seems to be enlarged? And there is some fullness. See, remember, this is the aortic knob, pulmonary artery, and this just kind of keeps going straight down. You see that? There's some fullness right in here, which of course we know is left atrium, isn't it? That's where the left atrium is. And so there's a bit of fullness there. But if we look very closely, there's also another border right here. You see that? Can you see it coming down over?
Yeah.
But not silhouetted.
Right.
Because it's a little bit behind it.
Yeah.
This and this is all left atrium. This, of course, is right atrium. Right atrium. The left atrium, when it enlarges, it's usually a stenotic mitral valve, or it's enlarging because the left ventricle is enlarging, and then secondarily causing the atrium to enlarge, which is most common today. To have the left atrium enlarge, at least initially by itself, was largely related to mitral stenosis, which used to be, of course, related to what?
Rheumatic fever.
Rheumatic fever, which was related to?
Strep throat.
Streptococcus pharyngitis, exactly, that went systemic. So why has mitral stenosis been on the decline?
Antibiotic.
Use?
Because of aggressive treatment by pediatricians, by testing and aggressively treating streptococcal pharyngitis. As a result, in North America, rheumatic fever has dropped like a rock. You greatly reduce the rheumatic fever, what happens to mitral stenosis? Tremendous reduction in mitral stenosis today. In the last 40 to 50 years, there's been a really tremendous drop in mitral stenosis. And it's for one only reason: aggressive treatment of streptococcal pharyngitis. That's why. So today, it's more common to have an enlarged left atrium because of an enlarged left ventricle. Things are just backing up. So this is an enlarged left atrium and likely related to mitral stenosis. There is a little bit of vascular engorgement, not a great deal of prominence of the upper lobe veins. Remember, heart can cause venous hypertension. Just backs up from the left side into the lungs. So we got a little cardiomegaly, some prominence of the left atrium, little bit of vascular engorgement, not much, and there's no evidence here that there's any reticular changes, there's no pulmonary edema, because it's still below the threshold for the edema. This one over here, I just put the overlay on top of this. See it? This prominence, left atrium, again. And what it's circling here is mitral valve calcification, which is right here. See it? Now, this is a barium swallow. The reason for the barium swallow is the left atrium's pushing a little bit against the esophagus. Not a great deal, a little bit. There's a little bit of hilar prominence, a little bit of engorgement in the upper lobe veins, but this is calcification in the mitral valve. And the mitral valve is located more posteriorly in the heart. The mitral valve, obviously. Left atrium is the most posterior chamber. And this is another individual with mitral stenosis. The mitral valve oftentimes calcified when it was stenotic. Aortic valves almost never calcify. I mean, they can, but it's pretty rare for them to calcify. And while mitral stenosis was largely acquired, aortic stenosis was largely
Congenital.
developmental. Yeah. And mitral valves quite commonly calcified. Aortic valves rarely ever calcify. Yeah. This was a mitral valve issue. Mitral valve. Okay, let's go and look at this one.